And good morning. I was relieved to see that Karen wasn't going to send out the people who got the wrong answer from the conference. You all got to stay, so that's a good start. So I'm going to talk to you this morning about patient-reported outcomes in heart failure, their role in potentially facilitating patient-centred care. I'm also going to give a brief overview of the feasibility study which I undertook as part of my PhD, looking at a palliative patient-reported outcome measure intervention and its role in nurse-led heart failure clinics. So it very much leads on from the discussions this morning about trying to empower the generalists, as in the non-specialist palliative care world, to identify where patients have general palliative care needs so that they can support those and address those, and then where those needs then would only be more complex, that they would refer to specialist palliative care needs. So what is a patient-reported outcome measure? Well, Fliss very kindly showed you what the IPOS looks like, which is the one that I used in my study. It's a questionnaire completed by the patient. Its usefulness is that it gives us the patient's subjective assessment of their own health status, so how they perceive their own health to be. They can be disease-specific or generic. Most importantly, when we're choosing which PROM to use, we want it to be valid, which means it measures what it says it measures, and reliable, so it measures the same thing consistently, and it's not overly burdensome to the patient. Now, there are hundreds of PROMs in existence, but generally speaking, they are designed to measure a few different domains. Health-related quality of life is perhaps the one you may be most familiar with, and that would be where they'd measure such things as the symptoms the person experiences or the disabilities they experience as a result of their illness. Patient satisfaction, utility, which is around cost effectiveness, and quality of life. And I just want to draw the distinction here between health-related quality of life. And McKenna has a very nice definition of this in his paper, where a person's perception of how their quality of life is how the illness has held them back from doing what they want to do in life, be it go to their bingo on a Saturday night, or, as a number of my patients in my study, going to Benidorm on their holidays. So it's whatever the illness is doing to hold back you from doing what you want to do, even be that hold down a job. So why use PROMs in heart failure? Well, principally to improve patient care and to improve patient experience. And as we heard this morning, this is a group of patients with a high symptom burden. They frequently underreport their symptoms, and the healthcare professionals looking after them poorly identify those symptoms. So we've got an unfortunate mix. There is a very high mortality rate with heart failure, and surprisingly it has a worse prognosis than all cancers bar lung cancer. There's a 40% mortality in the first year after diagnosis, and it's the commonest cause of hospital admission in the over 65s. And as Fliss alluded to earlier, it's an epidemic in the older population because the prevalence is increasing. Also, this is a chronic progressive condition with a limited prognosis, and the communication around future care planning, preferences of care, prognosis is very poor, and obviously patients suffer quite a lot as a consequence of that. Now, so this is a group of patients who have a chronic progressive illness. And frequently, a lot of them don't realise that they do have a chronic progressive illness with a limited prognosis. As we heard this morning, they're an older population, they have multimorbidity, they have a high symptom burden, and they're an age group that defer to the nurse or the doctor to make the decisions. And also, us healthcare professionals, we are not innocent parties either, and there was a survey published last year in the British Journal of Cardiology of British cardiology SPRs when they were implanting ICDs, or implantable cardiac defibrillators, and less than 10% of them had a discussion with patients about future deactivation of those devices. And I would imagine any of you have come across that situation, particularly in the hospice, where we come along as a palliative care physician and suggest turning off what the patients perceive as a life-saving device. The fact they've never heard that before, and someone they have no working relationship with, can become a real problem. One of my patients, when I was recruiting her and asking her if she had an ICD, told me, well, I have this thing, I don't know what I can't remember the name, I used to carry it around and it had an FIB in it, but the name has rubbed off, and she showed me this old raggedy piece of cardboard, and I could just make out fibrillator on it. bit of a clue what it was for. So it's to try and also give patients the information so they can make informed decisions. What we want, ideally, is to move towards a more patient-centered care approach. So insofar as the person wants, they can have more active participation in their care. So you may laugh at this slide, but this actually, and I apologise to my cardiology colleagues in the audience, but this actually is a lot of the time what's happening. Patients don't know what they're choosing or not choosing because they're not empowered to do so. So how do we look to address that in the context of improving their access to a palliative care approach? So patient-centred care, and I know Phyllis alluded to this earlier, and it's very much the philosophy underpinning a palliative care approach, specialist palliative care, where we put the patient in the centre. So what we want is a comprehensive review of their symptoms and their concerns so that we can open up a communication, a dialogue between the patient and the healthcare professional insofar as they want, and we can have shared decision making. And while there is no agreed definition of patient-centred care, there is a consensus regarding the common themes, such as respect for their needs, concerns, their preferences, their values, so that then within the patient and the healthcare professional discussion and collaboration, we can have a shared decision-making process where we can make decisions together and use both the patient expertise and the healthcare professional's expertise. So where do PROMs come into this? Well, a patient-reported outcome measure can very much work to facilitate patient-centred care, and as I've alluded to earlier, it gives us the patient's perception of their health status, not our perception. And Phyllis alluded to this earlier, where there's generally a big mismatch between what we perceive as the problems the patient has and what they perceive, and it can also be a means to identify unmet symptoms and concerns. By doing this, we are recognising the patient as a person, as someone affected by a chronic disease where it affects all aspects of their person, not just the physical. And we're also able to benefit from the patient's knowledge and their expertise of the illness. There's more of a thinking now where the patient, particularly with a chronic disease, is an expert in their own illness experience, and that's unique to them. So we want to actually be able to avail of that. So this dialogue, it sets up a discussion between the patient, the nurse, the doctor, the allied health professionals, so we can make decisions regarding what that patient wants, which is informed by their values, their needs, their concerns, their preferences, both for their current care, their future care, and I suppose from a palliative care point of view, whether they want quality of life over quantity of life, because often the complex therapeutic decisions that are being made are regarding balancing those two, the benefits and the burdens of the various treatments available. And also, I suppose with our population, it's not every patient wants to be actively 100% involved in their decision making, and many are happy to defer to the professional, which is fine. And true patient-centred care tailors the decision-making process to respect that. So it allows the person to be as involved or as not involved as they so wish. So their treatment plan then is influenced by this discussion. So then we ideally end up with a situation where the patient is supported to make their decisions insofar as they wish, while also benefiting from the skills, the expertise and the knowledge of the healthcare professionals. Obviously, we recognise the patient's expertise in their illness journey, but also acknowledging that they need the skills and the knowledge of the healthcare professionals, with the result that they will end up with more coordinated care. So if they have needs that can be addressed, say, by the cardiology service, but if they have needs that maybe need psychological input, social worker input, specialist palliative care input, these can be identified and addressed. So this was, if you like, the basic construct behind my PhD, is that how would we work to facilitate a patient-centred care approach in the clinics, so which is then conducive to a palliative care approach, which is then setting up for where these patients in the future may need specialist palliative care input. So the intervention that I looked at in my feasibility study was using a patient-reported outcome measure with healthcare professional education and training, because it's recommended in the literature, if you're going to introduce a PROM, you need to educate and train the staff who are going to use it on what it is and how to use it. And the PROM which I selected was the one which Phyllis mentioned earlier, the Integrated Palliative Care Outcome Scale. So that, which she very kindly put up on slides. So as you could see, it's quite short. It's 2 pages, it's 10 questions, and it's tick box. So a lot of the PROMs, you have to put them into complex algorithms to understand them, whereas the lovely thing with the IPOS, you can look at it, it's scored 0 to 4, so you can immediately see whether the person has got a symptom and whether or not it's severe or not. So it's visually very accessible. It contains a global symptom burden, but it's not just concentrating on the physical, it also contains questions on the psychological, the social, the spiritual domains. So it's covering all areas of palliative care, as well as the practical considerations of how their chronic disease may be affecting the person. And then there are the 2 open questions, which Fliss showed you as well. So that allows the patient to put in free text answers, so they could personalise the IPOS and really identify what the biggest problems where they could perceive. And this would vary anything from insomnia to one patient put down his daughter as his biggest problem. So it's whatever is your biggest issue. And so these were then scored 0 to 4. So it's very visually accessible, as I say. So the study which I undertook then was to determine and explore the feasibility and the acceptability of using the IPOS with integrated healthcare professional education and training, in other words, to the heart failure nurses, to see if it could improve the assessment and the management of the symptoms and concerns of patients with advanced heart failure. It was set in 2 nurse-led heart failure clinics in Dublin, was a mixed methods feasibility exploratory study, and it was involving patients with advanced heart failure. And I'll just draw your attention, so I included patients with class 2 to 4, New York Heart Association, and you will see in Fliss's RCT criteria it was 3 to 4, and that was because I'm stepping further back in their disease trajectory. If you remember back to Fliss's yellow blob diagram, so we're over a bit, we're earlier, because we want to catch patients when they have general palliative care needs, not when they're just end of life. And I could talk to you all day about that little small bit, but I won't do that. But the challenges of the New York Heart Association. So this is my intervention. So I delivered education and training to the heart failure nurses around patient-centred care, where the IPOS sat within that, and then training on how to use the IPOS in the clinical setting. Once I had done the training at the Mater in Beaumont, each recruited patient, as they attended the clinic, completed the IPOS as the way to be reviewed, and then the heart failure nurses reviewed the patients with the completed IPOS along with their normal clinical assessment. So this was a feasibility exploratory study, which means lots if you're in research and nothing if you're not. So I'll explain what that means. So feasibility is very much, is it doable? Can we do it? And it was an exploratory study because there has not been that much research using PROMs and palliative PROMs in heart failure. A feasibility study tests the methodological aspects of the study. So if we're looking to rolling out a future RCT, is this viable? Will it actually work in a clinical setting? Can we recruit participants? Can we retain participants? And then also, what did the patients think of the IPOS? And what did the nurses think of the intervention itself, the education and training and the IPOS? Was it relevant to their patient group? And did the components of the intervention work together? And most importantly, was there a potential for a clinical impact? So it was mixed methods, so we used quantitative data, and the patients completed questionnaires before and after the intervention, which of course themselves are PROMs. And then I interviewed 20 patients after the intervention and the 4 heart failure nurses in both sites. So the follow-up measures that I used were we looked at 4 domains: symptom burden, psychological well-being, quality of life, and health-related quality of life. To look at, again, this being a feasibility study, to try and see where the effect may potentially be with regard to using the IPOS. So I used the Edmund Symptom Assessment System for symptom burden, the Patient Health Questionnaire for psychological well-being, a visual analog scale 0 to 7 regarding quality of life, and the Kansas City Cardiomyopathy Questionnaire on health-related quality of life. And I collected data at baseline, so before the intervention, and then 3 time points afterwards. This was a longitudinal design that we used. So 1 to 2 days after the completed IPOS, 1 to 2 weeks afterwards, and 5 to 6 weeks afterwards. And the reason that I did that again was to try and see where the potential effect is. As you could see with the RCTs, Fliss mentioned that the time difference, you can miss the effect. So it was trying to see where we might potentially pick up a difference. So we did manage to recruit 38 patients. 25 were well enough to participate in the intervention when we rolled it out. And again, the argument in palliative is if you don't lose some of your patients, it means you're recruiting the wrong population. So I did manage 2/3 of mine made it as far as the intervention. The majority were male and married. Average age was 75, and most had New York Heart Association class 3. Now, the reason I've included the education bit is, again, that I'm using a PROM, so I need a certain level of literacy, a certain reading age, and this was an issue that came up with my population and with using the IPOS. So it's just, so as I said, about half the patients only did primary certificate and the primary cert. That was obviously the age of profile of my patients, and then some went on to secondary school, but most did not have a tertiary level education. And actually, just to go back there, I'm not going to present the quantitative findings of my study because obviously this is a feasibility study, so my study is not powered to look for an effect on the quantitative measures. It's more seeing, are these acceptable to the patients, are they tolerable? Of the 25 patients that excuse me, went through the intervention, 23 completed all 3 data collection points post the intervention, which I delivered by telephone, and I had 100% data, so no missing data. So it was a very effective way to collect the data for these individuals. Now, the 25 patients who completed the IPOS, there was a very small proportion of missing items, and of the 29 missing items, 19 were from 3 people. There was no particular pattern of what ones were missed, and appetite was the most common. It was omitted by 4 patients, so nothing very exciting there, that maybe there was one thing people didn't particularly like. Now, what I am going to focus on is the qualitative findings, as they were the most interesting. Obviously, I looked at the feasibility and the acceptability of the intervention, and I also looked at its potential to facilitate patient-centred care. In the interest of time, I'm going to focus more on the latter, but I just give you a quick overview of the feasibility and the acceptability. So the patients thought that the questions were appropriate to them. This is important because obviously the IPOS is a generic questionnaire, it's not disease specific, and obviously Fliss was telling you that we are working to develop a heart failure IPOS, but they felt the questions did apply to them. Also importantly, as I alluded to earlier, with regard to literacy levels, there were a number of patients who admitted to me they had problems with their words and their writing. And they said that the IPOS was fine, they could answer all those questions, they could understand those questions. And actually this was a problem I found with the Kansas City cardiomyopathy questionnaire when I was delivering on the phone. A lot of the questions, a number of the patients did not understand what the questions meant because they were just, the English was at too high a level. So the fact that the IPOS was accessible to these people was a coup in and of itself. Now, from a more patient-centred comprehensive system assessment point of view, the patients found that filling in the IPOS enabled them to identify symptoms. So that what they were finding was they had a symptom, they didn't know it was a symptom, they didn't know that dry mouth had a name, that they could go to the nurse and say, I have a dry mouth. They would mention it to the nurse, and then the nurse would prescribe a treatment. This was like a eureka moment for them. They hadn't realised that they had symptoms that actually could be addressed. So this was one unexpected finding, as well as that then with the heart failure nurses from the comprehensive assessment point of view, because in the IPOS is a question, are you at peace, or do you feel at peace, and there's a question about practical considerations, finance and so forth. So it's very much the holistic assessment that I alluded to earlier. And so this gave both the nurses and the patients an opportunity to look at all the aspects of care, and as well as that to potentially have discussions about, say, anxiety, depression, that are not that easy to bring up in a clinical interaction, but where the person had ticked 3 or 4, it gave the heart failure nurses the license to bring it up and to discuss it. As well, what came out as well, that the patients they put down their symptoms to older age, their other morbidities. They didn't readily acknowledge that the symptoms they were experiencing may possibly be from the heart failure. And so it acted like a symptom prompt to them, so that they could bring these then to the attention of the nurses and actually put a name on what they were experiencing. And I have a little more of that shortly. As well as that, I suppose what was for me the most interesting part of this was how it actually began to empower the patients. So these are obviously an older group who would all usually defer to the doctor or the nurse to make decisions. And what they started saying to me was that they realised that they could ask the nurses, they could bring these symptoms, do you have enough information? There's one of the questions, do you have enough information, or do your family have enough information? So it was okay to say to the nurse, actually, I don't have enough information, my family don't have enough information, and I want some more. It was giving them permission. And I don't know if I recruited a particularly competitive group of patients or what, but they were very excited about the scores, and they could see where am I, and they wanted to know where they were relative to other people, or if they filled it in again, would they improve? So that in itself was an entertaining finding. So also, as I say, it gave them the words to describe their symptoms. This lady at the top, she had just had a chest infection, and she said to me, I would have gone in and said, I have a chest infection, now I can identify the particular symptoms that I have. And the gentleman below, he didn't know the word for vomiting, he didn't know the word for nausea, and he didn't know the word for constipation. So the IPOS gave him those, and we assume the patients coming to us have the vocabulary, and often they don't, and we're asking them about a symptom that they actually don't know what it means. So it's just good to know. And then, I'm nearly done. And it also gave them the permission to mention the particular symptoms that they had. So this was a lady who had pedal edema. She'd had it for months. And you may think, okay, heart failure symptom, fine. It transpired her sister-in-law had pedal edema, ankle edema, and had died of cancer, and she was terrified that the edema was from cancer and she was going to die, but she never thought that she could actually ask this in the clinical setting. So it was giving them permission, if you like, to bring these symptoms to the nurse's attention. The nurses themselves felt that this was patient-centred, and it allowed them to identify all the different symptoms and problems the person may have and initiate a discussion in the clinical interaction. All, of course, is not rosy in the garden. This is an older group. They all need reading glasses. They consistently all forgot the reading glasses. If I was doing it again, I would buy a box of reading glasses and have them in the clinic. But one learns as one goes along, and it's such is the benefit of feasibility study. There's 2 pages. They'd forget to fill in the second page. The nurses were very good at reminding them. And now the IPOS is supposed to take 6 minutes to complete. It did take a little bit longer with this patient group, but not so much that it slowed up the clinical reviews. And there were a small number of patients who felt that it was the same questions anyway, but these were patients who also would call themselves active participants in their healthcare. So in summary, we found that a palliative-specific PROM intervention was feasible and acceptable in busy nurse-led clinics, and it ran well, integrated easily into their busy appointments, acceptable to everyone, and it has the potential to facilitate patient-centred care. So it was very interesting, exciting findings. And I've just added on to the end here. I know that Fliss was telling me everybody was asking about the IPOS. So not to be like running a free ad campaign for the IPOS, but sort of to be doing same. So this is the website, and registration is free. And there are 2 types of IPOS. There's one for every 3 days, which is generally for inpatients, and then there's one where it's every week. So over the last week, sorry.
That's not the frequency; it's the recall.
The recall. So every 3 days, or or after a week. The every 3 days usually you use for inpatients, and the one for a week usually you use for outpatients. So the one I used was in the last week. Have you experienced? And there's lots of really good stuff up there as well. So I just want to thank the patients and the staff who took part in my study, because obviously without them there would be no study. So thank you very much.